right.
So this is a middle-aged man who at an outpatient clinic associated with the university had this nodule, and then a couple of days later things had gotten bigger, and so instead of just a nodule we got this big blob of consolidation, and got a CT scan around that time which shows a dense nodule with maybe a little cavitation or maybe just a little air bronchogram or spared lung, and then some surrounding ground glass. So if I told you that he was hiking in Wisconsin in the fall with walking through leaves with his wet leaves with his dog, Jeff would suggest this might be blastomycosis, but this is coccidioidomycosis. And I haven't had a chance to look up what his travel history or his susceptibilities might be. But this is a pretty aggressive lesion for cocci. We usually don't see things that look like pneumonias, and this is a big nodule that got big pretty fast. This seems very aggressive for cocci.
Do you think it's bleeding?
Yeah, it could be hemorrhage around it. And
yeah.
So we start to think about angioinvasion and as a cause of hemorrhage and stuff like that. That's not been invoked in cocci. It'd be classic for aspergillus.
Does it happen with I don't know. Does it happen with cocci? It just looks like it looks hemorrhagey around it. I don't.
I agree. It also looks edematous around it too, so it's possible to use edema. But I've not encountered that before with cocci, but there's always a first time. So I'll see if I can get some more illuminating information about this. Okay, so that was an abnormal radiograph.
David, I'm sorry, did he present for symptoms like cough and fever, or was it something more vague?
It would have been symptoms to take him to the outpatient clinic.
Okay.
I'll try to clarify. Okay, this person has an abnormal radiograph, some basal consolidation. This is a 51-year-old woman originally from Kenya. Has been in this country for 6 years, has made some trips back and forth to Africa. So there's a travel history, and this is a radiograph. I think about a month later, there's still this basal consolidation. Heart size is okay, and mediastinum doesn't look bad to me on either of these radiographs. So there was a CT scan, and it turns out that there's this amazing amount of necrotic lymphadenopathy here in the neck and the mediastinum, with lots of enhancement of the edges. So necrotic lymphadenopathy, pretty extensive, going into subcarinal nodes and hilar nodes and lower down in the chest as well. And I haven't gone through the abdominal CT in detail. I'm not seeing any lymphadenopathy that's leaping out, but I'm wondering what this is over here. Maybe there's something going on there too. At any rate, let me show you lung windows on this person. There seem to be a bunch of tiny little nodules here. And on MIPS, those are even more dramatic. So let me bring up the MIPS here. So we have this profusion of small nodules, and this is all tuberculosis. There was a slightly earlier CT scan that showed accompanying pleural effusion. So pleural effusion is usually a manifestation of primary TB, so that suggests that this is primary TB rather than reactivation. But when you have such massive lymphadenopathy, you could get just passive lymph obstruction. So, the usual rule about the hypersensitivity response generating pleural effusion, if you've got massive lymphadenopathy, it really could be that causing the effusion rather than the beginning immune response to TB. But this was TB. The woman is HIV negative. There was no previous medical history, so there weren't any known risk factors here. There might have been some difficulties with language, so I'm not sure that that, whether they were able to ask all the questions they wanted, but there was no known risk factor here that would have promoted such an aggressive course of TB. And she had esophageal symptoms. So let's just follow the esophagus down. This is the MIPS. It's not the ideal esophagus view. Let me go back to this one. Sorry. So if we can find out why the esophagus is giving her symptoms, here is esophagus, and then you will see that there are these communications with some of these necrotic nodes adjacent. I showed a case about a year ago, I think, of coccidioidomycosis that had done the same thing. It had fistulized to the esophagus. Between the necrotic node and the esophagus, there was a communication like this. So this necrotic lymphadenopathy can fistulize. In this case, it fistulized to esophagus. So pretty aggressive pattern of TB, and presumably primary TB rather than reactivation. Okay, this person has acute leukemia and has some lymphadenopathy and quite a bit of hilar lymphadenopathy here. So this is unusual with a myelogenous leukemia, and makes you want to, when you see these tumor-like manifestations, you start to talk about chloroma or granulocytic sarcoma or any of the other names that it's gotten. We get down into the abdomen and things become even more dramatic with this massive lymphadenopathy surrounding the aorta. Really looks like lymphoma, but this is all granulocytic sarcoma or chloroma. And so this is a very extensive case of this. The current CT scans show that most of this has regressed, but there are still some components, but it's much better now after therapy. And let me show you what PET looked like in those early days at the time of this massive involvement in the soft tissues. So that was the upper abdominal component, and then here's that big hilar component. Here is an accompanying pleural effusion, subcarinal. So massive chloroma or granulocytic sarcoma. And I want to show you this, something that was new for me. Perhaps you've seen examples of this, but this woman has a biggish heart. On lateral view, it seems to pooch out posteriorly. So the first thought would be that this is left ventricular enlargement with this posterior bulge. But it turns out that this is actually right atrial and right ventricular enlargement here, and the left ventricle is being just pushed backwards by this massive enlargement here of the right side of the heart. And there was bad tricuspid insufficiency. And so she was treated with this new transfemoral device. This is this is called EPOQUE, P-O-Q-U-E, and is from the Edwards company. And this thing was placed via femoral approach. I think Howard might have shown one of these a few months ago or a year ago. I know that I've seen one of these really massive looking things before. I thought it might have been in this conference. Have you guys seen this device before?
Not yet.
Okay, there were just, the clinical trials I think just finished, and there's at this point there may be compassionate use. I don't know whether this was compassionate use or whether it's now been released. Here's a little diagram from the Edwards website that shows the mitral regurgitation, and then this device planted here. So it's got, there's a valve in this component up here, and then these prongs that point up sort of latch it into the fornices here around the tricuspid valve. So this is this component that keeps it sealed back toward the AV plane. Okay, so this is the EPOC device here, and they call this a TTVR, transfemoral tricuspid regurgitation device or something like that. Okay, so the new EPOC tricuspid device. Okay, guys, thank you.
Thanks, David. Those were great. All right, Seth or Travis?
I can go.
There you go.
All right. A lot of images with this case. This is cool. I'm sure someone else here has shown one of these. I've not seen this before. But you can see that on the short axis MRI that there is a fatty mass. We can tell that because of the chemical shift artifact, let alone the signal intensity within it, but mostly the chemical shift artifact. But you also notice that the mass is not just in the LV, but it actually goes through the wall of the LV, and there's this mediastinal component to it. Let me show that on this as well, just these T2s, or T1s, sorry. You can see here's this mass. A path of communication was kind of assumed. It's, you know, you're questioning some areas, but you can see fatty on both sides. I mean, there's probably 200 sequences in this MR, or sequences in this MR. So you can see nicely fat sats out. I'll show you it on the CT because this was first incidental. This was incidentally discovered on a belly CT, and you can see it's fat. So I'll show you the chest CT. No, don't load all data, 7 data sets. Sorry. Let me just load up one of these data sets. Oh, it's going to do it anyways. I'll show it to you on the CT. Anyways, it's all fat. Patient's asymptomatic, and it looks like everything about it is a lipoma. It doesn't enhance. It doesn't perfuse. You can see this. Of course, I choose the one phase that has all the motion on it. Anyways, you can get the idea that this is the fatty mass here, and that there is the kind of component in the epicardial fat. It's still within the pericardium. It's actually not mediastinal. It's within the epicardial fat. So we looked this up, and this has been reported before. Let me see if I can find. Well, I had it up a little. Here we go. So this is a what has been termed a giant infiltrating lipoma, where there's components both. I mean, this looks pretty identical, where there's components both in the ventricle and extending through the ventricle into the epicardial fat. And this was a case from China where they actually took it out, and it was all just lipoma. So has anyone shown a case of this here before? No. Okay.
I've never seen one before. So
yeah,
and there's no risk of like the apical portion causing thrombus or anything?
I don't know. I mean, we're not 100% sure. I mean, there's very few reports on this. I would be more concerned about, honestly, I'd be more concerned about arrhythmias, but the patient hasn't had any, here you can kind of see it going through, hasn't had any evidence of an arrhythmia or other kind of issues associated with this. So I think they're just going to follow it. But I don't know about thrombus associated with it. This is a case that I had just this morning that was shown to me, and it was initially called CTEPH, and you know, I kind of showed a few cases of this before, where you know there are some areas where there's kind of some thrombus going over the ostia, some vessels, but it's all extending from this layering thrombus that's sitting in the main or interlobar descending PA. You can see here, it's a little bit of an early bolus, so we have some smoke artifact. And then additionally, we do have layering thrombus sitting here, and that layering thrombus is extending over the ostium of some of the vessels. And I've seen this multiple times, and for some reason, it seems to really extend over the ostia of the right middle lobe and the lingular vessels. When I see this extensive in situ thrombus, I don't know, I'm guessing it's just the angulation of takeoff where it is. Also the posterior right upper lobe, even though that one's not involved here, I've seen involved with this as well. But this was just, you know, this is not CTEPH. This is just in situ thrombus extending over. You can see it's kind of layering here, extending over the ostium of this lingular branch here, which is kind of narrowed. But there's no disease elsewhere. And the reason for this, I mean, the patient does have horrendous pulmonary hypertension. I mean, there's no doubt about that. I mean, you can see how awful the heart is. I mean, the contrast in the hepatic veins, but it's due to his horrendous left heart disease. So, I mean, his pulmonary disease. So this is, you know, type 3 pulmonary hypertension, where we have seen, it's not common to see a lot of in situ thrombus with bad type 3 pulmonary hypertension, but we have seen it before. I have not seen, I don't think I've seen the calcified, maybe I have one case of like calcified atherosclerotic disease in type 3. You know, that's most seen in PAH and congenital heart disease, not usually in the type 3s or type 2s, except for congenital heart disease. Anyways, I can't remember. Some congenital heart disease is considered type 1. Anyways, that's that case. And then this is just, when I was shown this case, I was worried I missed something, which does happen. This was a guy who came in. So here he is on the study I read. There's really nothing here. And he's a bone marrow transplant. And this is literally 6 days later. It's really kind of nuts. Where he has what, for all intents and you know, we're trying to see what it's going to be, but sure does look kind of bird's nesty with necrotic lung in both these areas here. And then additionally, one of our faculty made a very good call, noticing that a lot of these veins are very irregular, and there's some areas of hypoattenuation. You know, I always get very hesitant about calling clot in veins or thrombus in veins, but that does look concerning. And then additionally, there's a bunch of PA branches that just cut off. Not this here, but you can see this branch just ends right here that were open previously. So I have to look to see what happened. But in 6 days, he developed what sure looks like dead infarcting, dying lung, and we're very concerned that it's going to be mucor from this appearance. But just the rapidity of it really, I mean, we know these people are immunocompromised, but the rapidity of it was quite shocking. So we'll see what bug it turns out to be, but that's our main concern, is for mucor.
So the rapidly developing fungal-like lesion that's even faster than mucor is Legionella McDadii. So I always have that on the list for what looks like fungus but grows super fast.
Really? Okay. I've never heard of that, but I'll let you know. Let me see. I mean, I can look it up and when you guys are talking and see if it's come back what it is. This was just the other day. We're always hesitant to say mucor because if we ever put that in a report, it just freaks everyone out and raises all these alarm bells. And so.
As it should.
Yeah.
That's aggressive looking.
Yeah. But yeah, those are my cases.
Cool. Thanks, Seth. Travis, you want to go?
Sure. I can show a couple here. Let me just make sure I've got everything else hidden that I don't want seen before I show this. Actually, I'm going to pause for 1 second. All right, you see a radiograph?
Yep.
I'm going to start with the lateral. This was a recent case that came in, and I think it's not the best example of this finding that I've seen, but it's a good example. And I think this just is a reminder that Pneumomediastinum can and is seen on the lateral view. And I think sometimes it can be even easier to see on the lateral view. And in this case, It's more of like a half ring around the artery, but the so-called ring around the artery sign where you have air encircling the right pulmonary artery as it shoots out to the right, kind of en face on the lateral view. I thought this was a pretty good example. And of course, you can see air kind of everywhere. And we'll look on the CT. Most of this is just extrapleural air along the anterior aspects of the lungs. And you can see, I think, even a nice outline of the intermediate stem line, probably some air around the left main stem bronchus here. And this is just a patient who, barotrauma, Macklin phenomenon, and they did a esophagram and surprise, no leak. I mean, not surprised, obviously, since there's no inflammation surrounding the esophagus and there's no fluid in the esophagus. But this guy's got a lot of air. He's got pneumorachis, but it was, it's kind of the stuff along the undersurface of the right pulmonary artery here is what you're seeing, and right here, I believe, on that lateral view. So I don't know, trying to guess where it's coming from. I would venture probably the left lower lobe, just because there's the most air surrounding the airways there, but I don't know. As in many of these cases, didn't necessarily find a culprit.
Travis, what was the barotrauma?
What's that, David?
What was the barotrauma?
Oh, asthma, excessive coughing.
Okay.
Yeah. So, but I thought it was a nice lateral radiograph.
How about at the apices? Was there any pseudo-pneumothorax at the apex the way there was on lateral view?
Yeah, you could see it here even anteriorly. Let's see, and yeah, I just kind of went quickly past the apices, but yes, there is a little bit, and you can see the little strands of connective tissue in there. So yeah, I think it's actually easier to see it anteriorly there and along the mediastinum. All right, this is a crazy case, and I actually saw this once at UCSF like 5 years ago. Had never seen it before, and let me make sure I've got the right images here. So let's see if we got the right dates. Yeah, and I'm curious if you guys have seen this, because I now have an N of at least 2, and it's the same diagnosis. So this is a patient who at this time had eosinophilia, may have had rash, other systemic symptoms, I'm not sure. Pulmonary arteries, they look a little biggish. These are thick section images back a decade ago. And then he gets a follow-up CT, and this is, as you can see, a year later. And check out the size of these pulmonary arteries here. And this is, his right ventricle is a little big, but he doesn't have massive pulmonary hypertension. And these are just huge vessels, corkscrew, and it's mostly arteries. The veins look reasonably normal here. He ended up undergoing a surgical lung biopsy, and a diagnosis was made. He was treated, and then 3 years later, his pulmonary arteries are basically back to normal size. And he was treated with immunosuppression. He was not treated for pulmonary hypertension or anything. And so the diagnosis that was made based on the biopsy and his rheumatologic workup was eosinophilic granulomatosis with polyangiitis. And the case I saw at UCSF, which I don't have access to those images because this is a Duke case now, but basically looked identical. And recent conversation with people back there, they said that one had improved with treatment as well. Have you seen this before, anybody?
No,
Absolutely not. Absolutely not. That's wild. I mean,
yeah.
I thought it was going to be classic PAH. I mean, I'm confused.
I was wondering whether it was going to be liver disease, whether this,
Right. Like hepatopulmonary syndrome?
Right. I mean,
where,
it was okay. He didn't have liver abnormality that regressed.
No. I mean, and you can see he's got we're trying to get the path because it's an old case that Paige had mentioned to me, and we were talking about something related, but no, he had a big surgical lung biopsy. We're going to get that path, but nothing else. And then he just was on heavy dose immunosuppression for EGPA. But I mean, I guess this is just vascular inflammation and dilation and enlargement. But
Travis,
No.
I
Yeah.
found a case report, which of course is like not available through any library, from Talmadge King's the senior author, so I presume it's from UCSF. They talk about, and I can't see the images, but they described irregular and stellate-shaped arteries on the CT, and then on the biopsy, they said the arteries were enlarged due to eosinophilic infiltration in the vessel walls, and the adjacent lymphatics were dilated. So I wonder if that.
This looks like the lumen is dilated. When was that published? Because the case we saw was new as of 3 or 4 years ago.
1990.
Yeah, yeah, that's what I figured. Talmadge hadn't done much clinical work recently. But yeah, I was just curious if anybody else had seen this, because this is just bizarre.
Yeah, I wonder if that's what it was, and maybe this one doesn't have the. I don't know. It's interesting, and it got better. So I mean, they were able to recover.
So
Amazing.
yeah, well, I've got two. I'm going to work with somebody there to write them up as a case series. Yeah, and then really quick, this is, I know Seth has shown at least one and maybe a couple of really good examples of this entity with dissection. And this is a patient who, and this is 3 or 4 years old, but I was putting together acute aorta talk and found this one. It's a good example. So you can see a flap just above the sinotubular junction, kind of in the expected location where we often see primary intimal tears and entry tears in the ascending aorta. And then of course the flap disappears for a while, and there may be a little bit right here, but you can see there is a dissection in the descending aorta as well, and the true lumen is entirely collapsed here. And then you get up to the arch, and you can see there's just this balled up mess, and it's actually occluding both the left common carotid and the left subclavian artery. And I remember, Seth, I think it was when you were at Maryland that you showed an intimal intussusception that like had all balled up into the left subclavian artery.
Exactly. You presented with cold left hand.
Yeah, and
that's crazy. Yeah.
Yeah, I have that. I used that case in my talk, in my talk, which is why I remember it so well. But yeah, this one, like the same thing. And I think it's just like, this can be tricky because if you're going fast and you just, somebody just sees the dissection flap in the descending aorta, could think that this is like thrombus or something and not realize that this is really the entirety of the intimomedial flap from the ascending aorta that's torn circumferentially and just intussuscepted into these vessels.
I'm guessing his brain didn't look very good.
Yeah, I don't know. Yeah, I don't know how much of this is complete occlusion or just really slow flow, but you're right. Yeah, I suspect it didn't look that great.
That's
probably a little bit more there. So
nice example.
The most dramatic example of an intimal intussusception that I've seen. So, all right, Jeff, I'll stop there.
All right, thanks. That was good cases. Yeah, I just went back. I had like 4 EGPA cases that I quickly pulled up, and none of them had funny vessels. All righty. Okay, so this first case is something interesting. I'm curious if any of you have seen it or have a better explanation than I do. So this patient has unclassifiable ILD. It's a basilar predominant, but doesn't. And he plays tennis, so he's able to do stuff. This was his old scan, and he's got this one area here along the fissure, and we see this all the time. We're always, is it a mass? Is it conglomerate fibrosis? But you can see it follows up along the fissure quite a bit away, so it's very elongated. I can make a sagittal, and it's actually been on his scan for a while. There it is there. See, it's pretty smooth, and it's very low attenuation. It's not dense or calcified. So he had another scan, and just some symptoms, but no infectious symptoms, and his fibrosis is roughly the same, but that area has excavated. It's got a nice thin wall. Well, I don't say thin wall, but the interior margin of this cavity is very smooth. There's no fluid in it. There's no stuff around it. And so the question is, I don't think I recall seeing this. If this was just conglomerate fibrosis, did an airway or something sort of obstruct? Is this just necrotic tissue? It doesn't look infected, at least now. Maybe he had an infection between the two scans. They're about a year apart. But have you guys ever seen something like this, where just an area of very dense fibrosis develops a cystic/cavitary space in it?
I think you have to worry about infection or tumor.
Yeah. Yeah, he's not
I
having
wouldn't.
any symptoms of infection. I did suggest follow-up of this thing just to make sure it doesn't misbehave, but it had been stable for a while, and I mean, there is some soft tissue around it. It's just so smooth.
The thing about fibrosis is, it seems to me if that were really dense scar tissue, it wouldn't allow a nice cavity like that to form.
Mm-hmm.
So this makes me uneasy.
You know, I've seen that, but not that big. I mean, I've seen these little dense areas kind of form cystic, and if they're in the lower lobes, then you get into the debate of what it is. But I'm not. Yeah, I don't know what that one is.
Yeah, I did suggest getting a follow-up. It's so clean looking. That's just what was odd about it.
Right.
Because if it were tumor, I typically expect to see some nodular component or something.
How about a PET scan? Do you think that might help?
Well, if it's inflamed, I'd rather just wait and see what it does. Okay, well, that's the first case. Let's see. Oh, this is an interesting case here. So this patient, gotta get these in the right order. Yeah, so this patient had a history of a dissection. He had an ascending graft repair, which is doing fine. And then they ended up at some point stenting the descending aorta here. And you can see there's the stent graft. And you'll see it's right up against the esophagus, and they've excluded this. And there's esophagus being pushed anteriorly. So there's this fluid pocket here. So this is a while back. And then the patient came in again. Let's get these dates right. So that's that one. So this is the next scan here. This is a non-contrast. And you can see there's still, everything looks good on the non-contrast. This is all gas in the esophagus there. So then the patient comes in sick. I don't have all the details of what that entailed, but you can see here, now we see gas in the excluded portions of the aneurysm sac in multiple locations. So esophagus is kind of stuck in here, but we have gas up here. So, and then you can see some pockets of gas here as well. So clearly not good to have gas in an aneurysm sac. And so they ended up having to go in because, very concerned about a fistula, and plus the white count graft infected. And so in the OR, they actually removed the stent graft. They resected the aorta, used a graft repair, and then they had to, there was a couple of fistulas to the esophagus. So they had to then, the thoracic surgeon had to come in and fix that, and they bring up a muscle flap to close that. It turns out, in retrospect, they had oversized the stent graft with respect to the lumen. I don't know if it was done, where it was done, but one of the complications, of course, with that pressure is it eventually eroded into the esophagus and then became infected from that. So this is an aorto-esophageal fistula that luckily was not fatal or anything bad like that, and the patient's doing okay as far as I know from the last time, but very unusual finding. So that subtle gas there is abnormal. And it's just tricky because you've got gas in the normal esophagus. So if there's ever a question, you can always use water-soluble oral contrast as well to sort out where it is. And you can see the leak here as well into the graph there. So kind of a messy aortic case. This case is a cool case. This patient was referred to us for pulmonary hypertension. And I was looking at the case, and you'll see already it's abnormal. And there's some motion artifact, but if you look at the main pulmonary arteries, you notice they're small, and there looks like there's some wall thickening, and you can get fooled by motion, but then you realize it's circumferential and it's everywhere. It's even going into the lower lobe, and now we're out of the motion artifact. So clearly there's a problem with these vessels. And then up top, you'll also see the same phenomenon going on with the aorta. It's too thick here, and then there's severe stenosis and then occlusion of left carotid. the thickening around the brachiocephalic and left subclavian. The distal aorta is all normal, and the scan actually goes all down the belly. So the patient is about 56 or so year old female. And there's what looked like old infarcts in the lung, these peripheral areas of nodular scar. So I suspect this is going to end up being giant cell. The differential would be, of course, Takayasu, but presenting after age of 30 would be very unusual. And then Behçet disease or Hughes-Stovin syndrome, but considering it's involving the aorta, and female patient Behçet would be really unusual to have pulmonary artery involvement, and also just it's rare in the US in general. So I suspect this will be giant cell involving aorta and pulmonary arteries. And there's kind of a, you can see the poor inflow in that left lower lobe compared to the other side. And then this last case is, it's an outside case. This patient presented with a cough, and they were worried about an infection. And I don't think anyone was expecting this. I don't think this patient had much medical care. But you'll notice when you open it, the first thing you see a massive pulmonary artery and a very large, angry right heart, severe hypertrophy, and you can see the pulmonary arteries are huge. So it looks like really bad pulmonary hypertension. So the first thing to do is look for a cause. And as we look here, you'll see there's right here, there's communication between the main pulmonary artery and the descending aorta. So this is, and this patient was 46. So there it is right there, and it's got calcium, which I remember David always telling me about with atherosclerosis there. So this is a patent ductus arteriosus that somehow slipped by for 46 years, but probably socioeconomic factors more than anything. And so really bad undiagnosed shunt and pulmonary hypertension secondary to that. And I have no idea what one would do with this.
Jeff, do they have a VSD too, or
I was wondering that. There's a lot of motion. It's not gated. A lot of breath motion. You wonder here if there's a VSD. But looking at the contrast,
I was looking more in the outflow tract before you windowed it, but it looks like there's a membranous septum there.
Yeah, so. I looked there too. And the thing is, the contrast density is different, and I don't see to seem a little jet. But yeah, that's always a tough area on a non-gated scan. I couldn't find any other congenital anomalies like any other ones. But it just looks like horrible. And then the lungs, you can see how much motion are factors, but just how big these pulmonary vessels are. But you see about ASDs presenting late in life, but I don't think I've ever seen a PDA present late in life. So just a patent ductus arteriosus and massive shunt. Okay, that's all I have. I think that's everybody. Well, great cases this week. And
can I show one case real quick?
Yeah, absolutely.
It's more of a consult. 1 second. Let me do this real quick. Sorry. I think it should be up here. Okay. Because this is similar. I forgot about this case. This was shown to me because it was initially, unfortunately, we repeated this study twice, and both times only got an arterial phase. I don't think we got a non-con. I think we might have had a delayed phase, but this was initially called by the residents a type A IMH, which I can understand it's circumferential soft tissue, but it's just around the ascending aorta. There's kind of areas of calcification that are external to where you kind of expect the intima to be kind of outside, and then it extends around the arch, and then obviously the abnormality involving just the central pulmonary arteries. The remainder of you can see how narrow the PA is here. The remainder of the vessels are normal, except she has raging atherosclerotic disease. She's a renal failure patient, and there's definitely wall thickening around the arch vessels, but the remainder of the vessels, don't look. You can wonder if that's atherosclerotic disease or vasculitis. So this was a vasculitis. I was wondering, a couple times I've been fooled is with, it's a vasculitis, but IgG4, I've seen mistaken for a type A IMH multiple times. I've actually seen So very good radiologists call stuff like this when it's just around the ascending aorta, a type A AMH and taken out, it was just IgG4 disease. So, you know, I think it's going to be a vasculitis, but I'm just curious if anyone else has any additional thoughts. I mean, a non-con would have been helpful, but I can tell you that a lot of these can even be bright on non-con. But you can see the smooth soft tissue around the aorta and just the central PAs.
I think the presentation can help. I mean, you'd think an acute IMH is going to cause acute onset chest pain versus more vague symptoms.
Yeah, I mean, she came in with vague chest pain. It was actually, yeah, she came in with kind of typical ER chest pain, non-specific chest pain.
Yeah.
But
yeah, I mean,
so she,
a large vessel vasculitis could be a giant cell in that area.
Yeah.
The cases of IgG4 I've seen, which aren't very many, tend to cause more mass effect. They're your PA, and I guess that's where you share that blood sheath. But the fact that the main PA seems to be spared argues against an IMH as well.
Right. So that's what one of our younger faculty said. Oh, you know, he thinks it's going to be a type A IMH because there was a shared sheath along. And I said, well, it doesn't make sense for the distribution and also just the appearance on the left side as well.
I mean, I guess it would be helpful. With that for vasculitis, the SED rate and CRP probably would be pretty high.
Yeah, I think she left actually her SED rate is normal.
Wow.
So her SED rate is 10. So I just looked it up. Her SED rate is 10. But she had a follow-up CT. This is the follow-up. I think she had an initial study a couple days earlier and it's completely unchanged. But she left AMA. So I don't think we're ever going to find out. But anyways.
Cool.
All right.
All right, everybody. Well, thanks for the great cases. I'll talk to you next week.
Thanks. Everyone.
Yep.